Today's episode is all about degenerative disc disease in the lower back. We'll talk about what it is, some misconceptions around this diagnosis, and then get into some practical steps towards the end to help you ultimately understand exactly what's going on. And a great place to start today is by talking about the use of the actual words in the diagnosis, and that's degenerative disc disease. It's that last D, the disease, that really I often take issue with, because in the mind of someone being diagnosed with this, perhaps even yourself, you think, oh gosh, it's a disease. Is it like malaria, some autoimmune disease? I'm going to have this and it's going to affect me every single day for the rest of my life. And that's simply not going to be the case if we deal with it correctly. So if you've had this diagnosis, just start by removing that last word and just focus on degenerative discs, because that is very clear. Often in the medical sphere, often in legal sphere, in finance sphere, the professionals have this jargon and these terminologies which unfortunately sometimes are wielded as barriers, so you don't understand what's going on, and actually having that layperson translation can really help you better understand that and actually feel like you've got a lot more control, which you always had, over the situation. And that's partially why we do these podcasts in general, is to try and translate some of the jargon that is maybe necessary when professionals are talking to themselves into layman's terms that you can really understand, because it doesn't need to be unnecessarily complicated with the use of words which perhaps have certain connotations. So think of it from this point on as just degenerative discs, and that way we can be much more helpful. And this is often crossed over in reports or in information from your various professionals when you get this diagnosis with wear and tear. And that really is a good point to start from. Wear and tear is fundamentally what this diagnosis is. And that's not to say, oh, well, it's just normal age-related wear and tear, because we'll get onto that in a little bit. But it is that specific discs, maybe it's your L5-S1, maybe it's your L4-5, the most common ones to be diagnosed with this, have been wearing at an accelerated rate. And therefore, they're showing signs of that degenerative process. And that's generally going to be identifiable on MRI imaging. We can also see it or understand it or infer it on X-ray imaging as well. But often we think of it as a binary diagnosis or a binary condition. You either have degenerative discs or you don't have degenerative discs. And in the mind often of you guys listening to this sometimes, it's more skews to the severe. When, unlike other conditions where we have something like, for example, a spondylolisthesis, where we have grade 1, 2, 3, 4, and you can very clearly understand where you are on the spectrum. With degenerative disc disease, you're not really going to have that scale, although you do. It is a sliding scale. It's not necessarily objectively passed out into the different levels, if you will. And that leads me on to the sort of the next part, which is how is it usually diagnosed? Well, it's going to be diagnosed through some form of imaging. Whether it's MRI, which is going to be more common, especially here in the UK, because that will be part of your natural procedure as you're going through the through sort of the GP and so on, or whether it's through X-rays as well, you get an understanding because you can see the disc spaces and the disc heights and the degeneration around the vertebral segment. But it's diagnosed with imaging, and that's where the first flaw comes in. And that is, imaging is a fantastic tool. And with something like degenerative discs, it's so great to be able to inform the patient, you specifically, exactly what degree the degenerative discs have degenerated. And that is by using the imaging. MRIs are actually quite good for this, because you see that the nice healthy discs are nice and big. You can see they're within their boundaries of the spine or vertebra. So you've got a vertebra on top, you've got a vertebra underneath, you've got a disc in the middle. Now, the disc should line up perfectly with the vertebral bodies. When it becomes degenerate, the inside of that disc is very clearly changes color relative to the discs above. So we can see, hey, whoever you are, you've got, your L5-S1 disc is more degenerated. You can see the graying that's happening here, and we can see higher up the spine, those are nice and white. They're glowing almost. And that's basically due to the contrast that's on the MRI that basically shows up water as being much whiter, and the absence of water, things get progressively more gray. So you can see the dehydration and subsequent degeneration of the discs very clearly, and start to get a gauge and go, actually, it's a little bit gray relative to the others, which are nice and white, or it's much more gray, or it's significantly more gray, and it's actually a lot smaller. The space, because the disc acts as a spacer between the vertebrae, which we'll get onto a little bit later on. I've got some notes up on the board here to make sure I cover everything for you guys. As the disc drops, it gets gray and it really starts to drop. It starts to bulge as well. Kind of think of like a tire that's been deflated. As the tire is deflated, it drops in height and it sags out to the side. So that's where we get those disc bulges occurring at the same time. It's just that it's lost its integrity. But the imaging is such a great tool, and it's a real frustration when, you've gone to the money or the NHS, perhaps in the UK, or you personally have gone to the trouble to get this imaging done, which isn't cheap in many cases. And it's there, you've got the images there, but you're just not given them. They're not used as a great informative tool to help you understand your own body. It's just a sheet of words, and words in that jargon that we referred to earlier, and you don't really have any appreciation for what's really going on. So because this condition is so commonly diagnosed on imaging, it really is a great missed, unfortunately, opportunity to help you get an appreciation for how to scale and how to grade your specific degeneration. If you've got the images, go and have a look at them. Have a look at how it compares to others, because that leads me into the next point. It's not old age. And unfortunately, the diagnosis of the degenerative disc disease might be made on the MRI or on the X-ray, and you go to whoever it is and say, oh, it's just age-related wear and tear, don't worry about it, it happens to everybody, or something to that effect. Now, granted, the longer we've been on the planet, the more chances that wear is going to creep in, wear is going to occur on the spine, and therefore, or to the spine, and therefore it's more likely. Sure. However, the big problem is the whole spine is not the same age, and you see this so clearly. And I would imagine that if you were shown the image, you would have the instinctive intuition to even ask such a simple question. Oh, well, you're saying it's just because of old age, and I'm in my 30s, 40s, 50s, 60s, 70s, 80s, whatever it is. Why are the other ones not like this? Because they're the same age. And that kind of just blows the whole age-related wear and tear argument completely out of the water, generally speaking, because they're not all the same age. Why is this one worn more than others? And that question is a question that all practitioners should be asking, and then seeking to educate, seeking to impart some of that wisdom and the questions that arise from that sort of line of reasoning, to start to discover, why is it the L5S one? Well, maybe it's because you spend 6 to 8 hours a day sat down. Maybe it's because you don't do any proper resistance-based work. Maybe you're not actually looking after your body very well, and your diet's not particularly good either. And you just haven't been taking care of you because you've been so busy taking care of everything else. And actually, we need to take a step back and start working intrinsically first to improve the overall health of our body. We'll touch on that a little bit more later on. But fundamentally, I've got a great example here that I remember seeing. This was very early on clinically, and I had 2 sets, and these were x-rays, but we had 2 sets of imaging. We had one from about a 25-year-old girl, and one was about a 60-something-year-old man, and both images, the lumbar spines, from a degenerative point of view, looking at the imaging, were more or less the same, pretty much identical. And there was the comment of normal age-related wear and tear in both on both radiology reports, and this is just it just is so difficult to actually reconcile this sort of statement. One person is 60, the other's 25. They have the same images. It can't possibly be normal age-related wear and tear because it's the same image and 2 people 40 years apart almost in age. It's just a very lazy way of talking about things. And it's almost a way, unfortunately, it sounds especially here perhaps, it's a way of kind of dismissing your problem. Yeah, so normal age-related wear and tear, just go away, go somewhere else. You know, it's not a particularly, that seems to be the way patients anyway over the years have relayed that information. Yeah, they just said it was age-related wear and tear and there's nothing wrong with me and I should just, my back's just the way it is. And that's not very helpful when you can actually glean proper information from the imaging. So that's just one anecdote. But there were many, many times when that sort of finding, that phrase, we've got some degenerative disc disease, it's normal age-related wear and tear, has been given to a patient. And that's where and then it's full stop. It's just normal. It happens to everybody. There's no next steps to help the person. And that's why so many people, I think, here do really struggle with their backs, because they get told it's just normal, crack on. And if it's just normal, then there's no next steps to offer any sort of support or help or education to go alongside that, to actually climb out. Because at the end of the day, it's not normal. There are different people with degenerative changes in certain areas, and actually going to explore why that's occurring. Although it's common, it's not necessarily a foregone conclusion that you have to have that. And then therefore looking into why it's in certain areas of the body, piecing that together with the individual, how they use their body on a daily basis and things that they don't do, can really start to inform us going forwards to make sure that we can help come out the other side and deal with this. So it's not a problem, degenerative disc disease, that is affecting us every single day. And we'll talk more about this in a moment. But what we want to get into next is what actually causes, what leads to the degenerative disc disease. And fundamentally, we have to understand that there are things that are going to accelerate the degenerative process. And really, they fall fall into two main categories. The first one is you have some sort of severe trauma early on, maybe in your 20s or a little bit earlier than that, or a touch later. And it's a raging disc bulge, let's say, a full disc herniation, and we lose some of the material in the center part of the disc, the nucleus pulposus, and that kicks off the degenerative process early. The structure of the disc has degenerated. It's not as healthy as it was. And therefore, if that's not properly rehabilitated over the subsequent months and years, then it will continue to progress or regress in the same sort of fashion. That's an extreme trauma. Maybe there was some significant fall or something like that. Then there's the more common, much more common variation, and that is the repetitive strain on a lower than optimal health individual, someone who's not eating the right sort of foods, who's not really taking care of their body properly, although they think they might be. We're not really looking after our health and well-being. Sitting for 8 to 10 hours a day is not good for us. It's not improving our health, and eating junk food and all these other sorts of things is not good for us. Again, I've mentioned on previous podcasts, we have huge waiting lists here in the UK, and we have huge issues of people being overweight in the UK and other countries. We as nations are not doing a good enough job of looking after ourselves. Part of that is there's not proper education. Part of that is that everything's made to be so confusing, from diet to exercise to this, that, the other, and therefore it leads to paralysis by analysis, for so many people, because they just don't know what to do and they don't want to do the wrong thing. So there's many reasons for that, which I won't get into. Some are acceptable, some are excuses, and that's by the by. But it's the reduced health and then the repetitive strain. So it's these repetitive strains from sitting for extended periods, moving inappropriately, constantly rounding the lower back to go down to the floor. When we have these low-grade injuries that slowly take hold and become more and more aggravated and heal less and less well between each episode. And there's not this commitment to proper exercise to rehabilitate and strengthen the body. And therefore, we just have what we have when we get out of our teenage years in terms of health and well-being and strength in the tissues. And it's just a constant downhill roll. And I use the example in the article that goes alongside the podcast of a single drop of water on a stone is not enough to cause a degradation. Our spines, our bodies are tremendous, organisms. They're very, very strong. They're capable of doing all sorts of things. And you only need to look at any sort of sporting videos on YouTube or any other place, Olympics, etc., to see what is capable with these things that we have. It's absolutely amazing. But water hitting that stone for hundreds and hundreds of years starts to erode it. And constantly using our body in inappropriate manners and not devoting any time to building strength and resilience leads to that slow degradation of everything. But when it's not just everything, when it's those movements always seem to focus stress at the same point, L5S1, L4-5, we start to see the degradation process occurring most there. And that's where we can intervene. We can say, hey, we can do something about that. You're wearing everything here because you're moving and doing all these things, which are focusing stress here. And we can change many of those things to start to improve the health. And one final thing before we get on to some of the challenges associated specifically with degenerative disc disease is you might be thinking, oh, great, okay, so it's degenerate, so I shouldn't do anything. And when we were doing a while ago the running podcast, the one talking about running and et cetera, one of the interesting bits of research that I was looking at the time, and I might do a bit of a butcher's job covering this, but essentially it was looking at regular runners who were running, I think it was about 30 to 40 kilometers or miles a week for long periods of time, i.e. for many, many years at a time. And they actually looked, because you'd think, oh, well, if I do stuff on my disc, it's going to degenerate. No. If you do the inappropriate things to that same disc over many, many months and years, it's going to create a problem. But if you're regularly providing stimulation through, in this case, running, they found that the discs, the lower lumbar discs of these athletes who were certainly wearing and tearing the bottom part of their lumbar spine through significantly greater than average impacts through that spine, were actually larger and more healthy than the average population when they were looking at them on MRI imaging. How does that make sense? Surely they're wearing and tearing their discs more. No, they are building strength and tolerance, and they're providing an element of challenge, an element of wear to them, but they're giving themselves the appropriate time to recover. They're also looking after their nutrition. These people are eating well. They're hydrating well. They're doing all the other things that go alongside the regular wear on the discs. And that's fundamentally how we make any of our tissue stronger, be it the muscles from resistance training, the bones, the joints, etc. It is putting load through a tissue, maybe in the case of the bones, or strain on a muscle that creates a little bit of damage, but is done as part of a program or a plan of action, focused work to create a little bit of damage and then allow the body time to heal and recover. The problem is when you're 8 hours every day sat in front of the desk, and then you're going and rounding to put your shoes on, this, that, the other, it's a constant torrent of abuse. So if they were, for example, running ultra marathons, these runners, every single day for a week or a year, then they'd start to pick up injuries. And you see this sometimes on people that do these challenges. Their bodies basically break down when they do these, I'll do a marathon every day for 50 days. They start to get issues. They start to get maybe shin splints here where the tissues fail beyond what is acceptable. So there's that to consider as well. But most of you watching this will not be anywhere near that sort of level in terms of the intensity that you're doing things. But the reason I bring this up is to say that don't be shy if you've got degenerative disc disease and you've got that diagnosis in the lower back of doing things. We have to do things because that's how we build up strength. And we'll touch on that again towards the end. Now, what are the main challenges when it comes to degenerative disc disease? Well, there's two main ones. Number one is that we get a decrease in the size of the disc. And this disc acts fundamentally as a spacer to space out two segments. And it's helpful often if we think about the spinal discs, but when we're looking at lower back issues, think of it as a segment. We've got the disc on the front, which separates two vertebral bodies. Then behind that, we've got a little hole through which the nerves come out. And those are the nerves that go on to, for example, form the sciatic nerve. Then on the back, and you can see just over my head here, you can see this little spinous processes sticking out. Between all of those, we have ligaments, and we have just behind the hole where the nerves come out, we have the facet joints. Now the disc acts as a spacer for the segment. So if the disc is acting as a spacer and it drops in height, we all of a sudden get smaller holes. We get a smaller hole where the nerves come out. And that is akin to having a lift that's supposed to take 10 people. Now all of a sudden the lift shrinks and now it's only able to take 8 people. Why is this a problem? Because if you have regular flare-ups or aggravations, it takes a smaller degree of inflammatory reaction to build up in that little hole to fill it up to create symptoms. Quite often, the symptoms that we get with flare-ups, with something like degenerative disc disease, it's actually mostly, yes, there's a little bit of damage to the soft tissues, maybe the disc material, or maybe some of the facets or ligaments around there. But it's often the inflammatory reaction that takes place in that area that fills up that hole, creates pressure, and creates this feeling of needing to do certain movements, forward bending being a classic one that we should really be avoiding. So that's really one of the biggest challenges. The holes just get smaller. And all those ligaments that are running from A to B, now all of a sudden they've been kind of taken off stretch a little bit and they kind of go a little bit loose. The best way I used in the article of thinking of this example is if we've got ligaments that are supposed to be pulled taut like an elastic band, what happens when you shorten the distance between A to B? The band gets a bit thicker and it sticks out a bit more. Maybe even if it goes a certain degree of shortening, it's actually going to start to look more like that flat tire that we discussed earlier. It kind of folds itself a little bit. And that folding, that bulging a little bit of the ligament because it's been taken off stretch, that's going to occupy the space further and create a little bit more in the way of impingement on that hole. We see this as common findings of things like ligamentum flavum hypertrophy is a bit of terminology. That's just basically saying a ligament seems to be a bit thicker where it shouldn't be, essentially, on the imaging. So we see those sorts of things. But the second problem that goes alongside that dropping of height is, like I mentioned, those ligaments are all supposed to be pulled taut, pulled with a degree of tension on them. And that tension works to maintain the spinal alignment. That means that the spine is already primed for movement. When we do at one segment where we have degenerative change, we all of a sudden loosen the ligaments a little bit. We have instability, which is the second problem. Now, all of a sudden, those ligaments aren't tight and taut and holding everything primed for movement. There's a little bit more available wiggle to happen down there, and that's that instability. And I use this as a good example of this is in the car seat. When you're driving, you're told from childhood, do not pull the seatbelt forwards, because if we stop suddenly, it's going to hurt you. Why does it hurt you? Because we create more room, we create slack in the system. And then when you suddenly brake, you fly forwards, hit the ligament, all of a sudden comes onto tension. Sorry, not the ligament, the seatbelt, but you get the idea. The seatbelt all of a sudden hits tension straight away, and boom, it fractures one of your ribs or rips the seatbelt a little bit. That's what happens in the lower back. Instead of the car as an organism and your belt nice and tight because everything's primed, as the car brakes, the whole organism takes some of that load and slowly decelerates. You fly forwards and then hit a sudden wall of that ligament. So those ligaments are wobbling around a little bit, and then all of a sudden they come on, boom. And that's what creates, and that's one of the reasons why this instability leads to those more regular flare-ups. So it's not that they're often that severe in terms of the damage that's caused, but you've got this increased propensity for minor flare-ups to take place in an area which has a decreased propensity to deal with the inflammation that builds up as a result of those minor flare-ups, which is why it's so difficult. And that's why it leads us to the next point, which is the temptations to undergo movements like flexion, child's pose, knee hugs, whatever they are. We are trying to alleviate some of the pain. We're trying to bend forwards to open out that hole, because that hole has artificially got smaller because we keep aggravating ourselves. And that unfortunately then pulls on the ligaments that have been damaged a little bit more by that particular flare-up, preventing them from tightening back up again like they're trying to do. And we kind of perpetuate the cycle. It's almost like consistently scratching an itch after you've been stung by stinging nettles. The stinging nettles are making you in pain. The problem is that you got stung by the stinging nettles. You had the flare up. The stinging nettles are creating that pain, and you want to scratch. And by scratching, you're creating more damage to the skin and allowing those little barbs off the stinging nettles, the fibers, to go deeper into deeper layers of the skin, which are more sensitive, therefore creating more aggravation, therefore creating a greater need to itch. So we scratch harder and we get stuck in this vicious cycle. And it's the same thing, or a similar thing, when it comes to certain exercises that we habitually choose when we have degenerative disc disease. We're often given the knee hugs. Why? Because it makes that hole larger. And that's what you have to understand. And we've got many other episodes where we talk about flattening of the lumbar spine. We talk about the towel exercise. We talk about why these exercises are bad in great detail. So you can go and check those out. Maybe if that's of particular interest to you. But what reinforces that feeling of bending forwards being a good thing, which it isn't, is the fact that when we do something like the cobra, it hurts. Why is that? Because there's the instability there. Instead of bending backwards, the spine shears a little bit when we do that, because those segments aren't held taut. And that creates more or less instant discomfort, often quite a sharp pain in the lower back, and really discourages going, oh, well, I definitely shouldn't bend backwards because that hurts, so I'll bend forwards more. And that interplay of those two, one making it feel worse, which is bending backwards, and the fact that bending forwards feels good, makes us further gravitate to the forward bending and get stuck into that loop, like the stinging nettle analogy. So what do we do? Because it sounds very complex, and there's lots of different confusions around there. Well, moving forwards, it's very, very simple. And we've got 6 steps that will hopefully help you better understand this and be able to move forwards effectively. Because at the end of the day, we've seen so many people over the years with this particular diagnosis, and there's absolutely no reason that you can't get back to doing the things that you want to do and being pain-free. But the very first step is you need to use the diagnosis for action. That's number 1. Understand that it's not a muscle spasm. It's not this, that, the other. There is the hallmarks of consistent, over time, abuse to that lower back. And you have to understand that degeneration is not a process that takes place in a few days, weeks, or even a few months. It's taken place over many years. And also, at the same time, in that same breath, it will have been degenerated before you had the pain also. And that's quite a good thing to understand. But know that it's not something that's just going to go away. And then step number 2 is understand the challenges that it has been there for a long period of time, and it's not just going to go away, so you don't get demoralized. If your expectation is that it's just this, that, the other, it's just something minor, it should go away, you're going to get really demoralized when it doesn't. And once you understand the diagnosis and you take action, and you appreciate the challenges that go alongside something like this, such as I've just mentioned, the decrease in size of the hole and the instability at the segment, the fact that relapses and flare-ups are a little bit more common on this journey to getting your back fixed, you feel a little bit more prepared for the task at hand. You're not under false expectations, and when the false expectations get eroded or get derailed, it makes you very demoralized. This will guard you against that demoralization, because you know what you're in for going forwards. Then comes to the actions. Work on stability. This is the sort of stuff we talk about in the program at length. You need to work on providing stability to your spine. That's not moving forwards and that's not moving backwards. That's providing stability. The ability to hold it steady. When you have that instability there in the lower lumbar spine, it's little movements around the house even that create problems, because that instability is there and you're not holding your body, you haven't learned to hold your body steady in that core section. Now you see people saying, oh, you shouldn't be so rigid, etc., etc. That's fine when you're fixed. But when you're in the throes of actually recovering from these things, we need to start by providing stability. Why? Because by providing spinal stability externally through the engagement of the core muscles, engagement of appropriate posture, etc., you're going to provide protection so that healing can start to take place and start to build some momentum. The further along the healing process we go, the less problematic a flare-up will be. And the simple example here is, if you have a scab on your hand where you've cut yourself, if you peel it, the first day the scab comes off, the first day the scab forms, it's going to bleed loads. A week's time, if you accidentally knock a bit of the scab off, it doesn't bleed as much. It bleeds a little bit. And that's really what we're trying to do here. The problem is, when we're so unaware of all the challenges that we face on a daily basis with this specific condition, with the instability and with the decreased hole size, leading us to want to do the wrong sorts of exercises. We're not aware of that, so we keep aggravating ourselves. Build spine stability first so we can protect and allow some healing to start to build a bit of momentum. And those are the sorts of exercises we talk about in the Back in Shape program, starting from the very safe, putting you upright and going on from there. The next step is from the medium to long-term point, we need to start to scale the resistance and build the strength in our body. And that does, yes, involve at the right time, putting a bit of loading back through that spine, putting a load through those structures so they can start to figure out how they need to rebuild, how they need to strengthen. Often people really fail with their back pain recovery because the healing process starts taking place. The wound starts to patch up. Again, I use the example slightly different here of a broken leg. While the leg is still in cast, you do not often have pain. The thing is with the broken leg is that the cast clearly tells you it's still healing. With your back, you don't have that. So, but also when you come out of that cast, you have to do some rehab because you've had a cast on. You're aware. You can see the visible muscle wasting that's there, and you're aware that you need to slowly rebuild, put a bit more load back on that to help the bone develop. Help the muscles around that develop. Well, the spine is no different. It is a load-bearing structure. It has failed over many years, become degenerate in loading. And just like we discussed with the example earlier of the runners, rebuilding with resistance on the spine steadily over time will help build in the resilience to your spine, both the segments that are injured and the ones around it, so that it can become stronger. But you do that with resistance and load. And often it's a very daunting prospect. It's a daunting task. We're a little bit nervous. Am I going to make things worse? Am I going to aggravate myself? And having a little bit of support along the way can really help and make the difference and give you that confidence to move forwards. But doing it conservatively and not trying to rush things again, know that this has happened over many years and it getting better, we can steadily scale our resistance over months and years rather than trying to do it all in 6 weeks. We will be much better placed, and that kind of recovery is a recovery that lasts rather than 3 to 4 weeks thinking everything's going to get better and then boom, we have the relapse because we didn't do it properly. Point number 5 is really aiming for 2 things, and this is more of a long-term goal. And the degree to which you do this is based on the degree to which you have more severe change degeneration wise, because often when these discs become significantly degenerated, you get a degree of bony spurring around the vertebral bodies. We get other facet hypertrophy is another thing that comes along with this quite often, and that is that the bony architecture has changed, and once that's changed, it affects the structure at that level. No different to if we've had, say for example, a spinal fusion. We have to acknowledge that our spine now is going to move, has its capacity for movement is going to be limited in some way, shape or form, and something else needs to try and do the work so that that spine segment and the one above it doesn't have to do so much work. And our body is absolutely marvelous at adapting for this. So that's very important that I say that. But we need to work on having greater than average, for your age, for your gender, whatever the case may be, greater than average strength in the back and in the legs. That's the hips, the knees, the ankles. And greater than average hip flexibility being particularly important. And alongside hip flexibility, you're going to have knee and ankle flexibility as well. Why? And I put strength first there. Strength is what gives stability. Flexibility gives us that range of motion. Why? Because if we build that strength and flexibility in the hips, knees, and ankles, but hips most importantly, then we have a joint very close to where you most likely have the degenerative change, because it's most likely going to be at L4-5 and L5-S1, or most profound at those levels. You have the hips, which have a huge range of motion, which are strong in all of those ranges of motion in terms of the joint is. The muscles might not be, and that's something that you work on over time. But that can take the load. So if you're going to play with a little one on the floor, or if you're going to have to go down there to do something on the floor, or go up high, or get in and out of a chair, your hips are the things that move. So your spine can maintain the best possible position, and can do that because you've built a good stability and spinal stability earlier on in these steps. So building that flexibility and strength in the hips is going to be vital for your long-term success, and something that you must consciously work towards. Often people with this sort of diagnosis go, I'm degenerative, I've got to be careful, I can't do that. And actually it's really the inverse. There are so many cases. Another example is to say that, oh, I'm super busy right now, I can't do my exercises, or I can't do my good things for my back because I'm so busy. And that's the exact thinking that got you into the back pain in the first place. And back pain, unfortunately, is one of those things where you can ignore it, and then it'll make you not be able to ignore it. And when it decides that you need to deal with it, it's often the most inconvenient time. So when you think you're busiest, that's when the need for you to do these things is so much more important, because you're doing more bad stuff in most cases. And when we have more degenerative change, we need to focus more on building strength than the average person, because we will get away with less. We can afford less to have relapses and flare-ups. Why? Because again, as we discussed, we've got that smaller hole, and therefore a smaller flare-up for you will feel a little bit worse. Even a smaller flare-up for you in the L5S1, where you have that degenerative change, compared to a flare-up or aggravation at L1-2. The same injury will basically be almost a non-issue at L1-2, but down at L5S1, it creates debilitating sciatica down the leg. So understand that you must do these things to a greater degree if you have a greater degree of degenerative change. And I would argue, if you don't have the degenerative change, do it anyway, because it's going to make you more resilient for the long term. Anyway, so that's something to consider as well. The final point is, you can be great with all of your exercises. You can do a great job there. But if you do not address your daily life and the way in which you use your body on a daily basis, you will come up short. You're just going to end up not getting the lasting relief that you need, not making the significant changes in your body and your daily habits that allow you to get back to doing whatever you want, irrespective of the fact that you might have a diagnosis of degenerative disc disease at L4-5 or L5S1. You must, for example, if we're sitting at a desk all day, get a sit-stand desk, or get one of those standing desks that you can sit on the desk. You can sit on the desk, so you can go from sitting to standing. Make modifications to the way you do things. If you can't go down onto the floor to play with a little one, let's say you've got a young child, something like that, you need to learn to get down there through knee and hip flexibility and mobility and strength down there. The reason that you're rounding your back or you're struggling to go down there is because those things aren't healthy, and they're then straining your lower back. You need to modify some of these things. If you're out in the garden and you're standing like a giraffe drinking water, rounded the lower back, going down there, putting all sorts of strain down there, you need to change that. You need to think about these things. Take the lessons of spinal stability in point number 3 and strength, and apply those to the activities that you're doing out there in the real world. If you do that, and you do those 6 steps, you will have much, much more success in overcoming the diagnosis you have. And it could be degenerative disc disease like we've talked today. It could be a herniated disc. It could be many other things. It will really make a profound difference. Understanding through education what's going on, and then taking those steps to really improve the strength and resilience of your back, and not being afraid of adding a little bit of load, because that is what builds strength. And the reality is, as we've discussed in previous episodes, you will be carrying load. Even if you say you won't, you're going to pick up the 3-year-old when they're unhappy. You're going to pick up the holiday suitcase when you're going away. You might need to move the sofa, and you're probably going to take the shopping into the house or out of the house. And that might have a large carton of milk in there too. All of those things are weight. So do not have that irrational fear of doing resistance work, as long as you obviously do it at the right pace and build it steadily over a period of time. That's enough rambling for me today. Hopefully that has been a really helpful episode for you. We've given you some actionable tips towards the end of there. And of course, if you're in the Back in Shape membership, as I know many of you that watch this are, you're already doing the right things. If you've got any questions that have come out of this, then use the comment section down here to let us know. We can clarify any things that you aren't quite sure about. And again, as I might have mentioned at the start of this, much of what we've discussed here applies to the same diagnosis that's made in the neck. Yes, the nuance of what we might do from an exercise point of view and the changes that we might make might be a little bit different, but much of that same that same understanding, that same features and challenges of degenerative disc disease up in the neck are going to echo what we've discussed here about the lower back. So thanks so much for joining us. Hopefully this has been a helpful episode for you. If you did find it helpful, or you know someone else who's struggling with their degenerative disc disease, they've been told they've got wear and tear and it's just normal, and they, whatever, then consider sharing this episode with them. Remember, you can subscribe to the channel to stay up to date every week when we release the podcast. And until next time, have a great day.